So how do you increase plasticity in the brain? You'd increase secretions in the vagus and let the vagus do the work. I ran just 970 and 27. Terror. Not kidney fear, not worry or over concern, but terror. And the belly softened and she just fell asleep.
One thing we hear a lot of is patients or practitioners want to jump to the emotional frequencies right out of the gate and forget about the physical exam and forget about the physical findings. But if you think of it in the most simplistic terms, that there is something robbing the body of healing because its energy is directed somewhere else.
Thank you for subscribing to the Frequency Specific Microcurrent podcast. FSM is a breakthrough tool for medical practitioners who feel stuck with limited treatment options, especially for complex issues unresponsive to conventional care. FSM training is the best continuing education course for medical practitioners. Get our free introductory webinar at frequencyspecific.com/about or find FSM trained practitioners at frequencyspecific.com/find. Here's Dr. Carolyn Kim Pittis.
Hi.
Hi.
How are you?
I'm great. You look very pretty.
There was I got the white memo.
Well,
and my sweatshirt is in the dryer. There's that.
No, this is just one of my cozy, it's that funny California weather where it's getting warm. The house is colder than it is outside. Yeah.
This is funny Oregon weather because it's sunny. And that's weird. And the thing in Oregon is if you don't like the weather, you just wait.
Right.
20, 30 minutes, 60 minutes. It'll change. It'll rain. One day we had sun, rain. Then I was up on the 32nd floor in my lawyer's office looking out the window, and there was hail. Then there was snow, and then rain again, and then sun, all before I left the building.
Well,
it was fascinating.
That's all the emotions you can see within an FSM treatment.
Oh, I'm so glad you said that. Can I tell you what I did Monday?
Yes, because, and I'm just going to put it out there as you tell us your stories, is my idea, the destination on the train today was to talk about the layers of a treatment, whether it's different emotions that can come out or when pain seems to go away, but then when pain comes back and how to
navigate that.
How to navigate it all. But why don't we start with your story?
This was a patient with a severe history of early childhood trauma. Ended up in the emergency room. And then she got septic abdominally, and they missed it because they were in a rural area. And then multiple layers of trauma and almost generational. And her present day history, she's licensed medical professional, and she got COVID and then had started with vagal dysfunction, then started with clots, and then brainstem TIA or stroke, and then the posterior fossa, which included the eighth nerve, so it included a portion of the pons, which gave her a central vestibular injury. And she had body pain. And so at one point I had 9 machines on her. But the first day, it was the physical stuff because her neuro exam showed disc bulges and leg pain and stuff like that. And then, so we treated nerve, her reflexes were normal. So +2, cord was fine, but increased tone. So that was 81 and 10. reflexes are normal, that I don't understand. And the way she talked about the trauma meant obviously concussion in Vegas. But after reading Patrick Wood's slides and seeing what the thalamus does, and the thalamus plans the future, takes you places. And Dr. Wood and I are going to have a conversation this weekend, because I have a feeling, since the hippocampus is right next to the thalamus, the subconscious or buried memories link up with the thalamus and its planning. And so you end up driving towards or imagining or reliving those events. And she said, because she has a custom care, and she said, I used to run PTSD, but doesn't really do much. The concussion in Vegas is the best. So if you think about what the thalamus and the hippocampus do to memories, so she has auditory flashbacks. And since COVID, since this damage to basically the midbrain, if you look at neuroanatomy, the place where the eighth nerve is in the pons is just right next to the thalamus and the hippocampus. So since the COVID, she's had auditory and visual and intrusive flashbacks. And at night, in the daytime, all of it. So I had one machine running from her neck to her abdomen on quiet the midbrain, 40 and 89, and then increase secretions in the vagus. So if you look at that diagram of it increases the good stuff and decreases the bad stuff, that diagram of the vagus webinar, one of the things it increases is brain-derived nerve growth factor and something that makes axons grow. So the effect of the multiple strokes that she had because of the clots from COVID, she had, like, at one point her left side of her body didn't work. And then afterwards, she had a distorted sense of herself. So right now you have a map. If you close your eyes, you can see your body. There's a representation of your body, and you know where your arms and legs are, and both sides are the same. When she closed her eyes, her right side was really big and her left side was smaller. So there was a disconnect between the two sides. Now, think about the neuroanatomy. There's a little dead spot someplace. I can't say I know where it is, because I don't know where that body image lives, but there's a little dead spot. Okay, so if you can increase the neurochemical that makes axons grow and makes BDNF, brain-derived nerve growth factor, if you can think of axons getting to the dead place and going, we can't do that, but I wonder if we can build around it. So that's about brain plasticity. How do you increase plasticity in the brain? You with me? Okay. So how do you increase plasticity in the brain? You'd increase secretions in the vagus and let the vagus do the work. Okay. And she's got mast cell activation like to the max. Her cheeks were that red ribbon behind you. Her cheeks were that color. She's on every mast cell drug you can think of. And It's how do you control mast cells and macrophages? The vagus does that. So I ran 81 and 109, and each of her treatment sessions was 90 minutes long. So that ran for 90 minutes, plus multiple repetitions of concussion and vagus, and 40 and 89, and then worked on the physical stuff. And because of the sepsis, and then she had an ovarian cyst explode and bleed all over her abdomen. So we did her psoas on both sides, and I just treated scarring in the vagus in her abdomen. So what turns the vagus off? COVID is going to turn it off. But she's had trouble with this even before COVID. It's the mast cell activation exploded after COVID. I can get rid of scarring in the vagus because every time you stand up, your guts pull it down and make it worse. And because the stroke was just above the medulla, her SCM and her upper traps were like bricks. Her legs and her trunk were really tight. So one machine is running on 81 and 10. Y'all with me? So we've got concussion in vagus. She's got a 4-5 and a 5-6 disc. So we ran those. And we ran 81 and 10 neck to feet, neck to abdomen, quiet the midbrain. And what was interesting and what made me think of, I have to tell this story. I wasn't going to, but what made me think of it was she was talking about the trauma over and not over and over, the whole story from age 5 to 14 or 16 when she left home. It's vivid. It's now. It's in her head. And I ran 40 and 89, and it took about 10 minutes, and she stopped talking about it. Then as I was working on the vagus, I got to just below her xiphoid, just below just at the diaphragm, just below the rib cage. And it was like a rock. So we did scarring in the vagus, that did a little bit. And she's talking about stuff. And I thought, there's an energy center there that is about survival. It's about identity. I wonder. So, as you'll see in the advanced, balancing the solar plexus. Now, in concussion in vagus, we've already run trauma and 970 in the solar plexus. But now I want to balance the energy center. And
35 on 2.
35 and 200, right?
Sorry, yeah.
Okay. So we have the energy centers from the solar plexus up to the crown.
Mm-hmm.
But there's no way for the crown. We've run the concussion protocol multiple times. She has. And her solar plexus is still like a knot. So balancing the solar plexus, and this thing finally softened. And then one of the things that happened was that her hyoid got fractured in this same violent episode. And so the vagus runs right down next to it, behind it actually. So the bleeding from the fracture, the hyoid bone is the only bone in the body that's not connected to another bone.
Like the patella, kind of, but not.
Yeah. So you're the knee expert. I'm so excited, the middle child syndrome. Anyway, so solar plexus, heart, throat, brow, but I'm not going to tell you what that frequency is until the advanced, and then crown. And you do them in that order. And she was so dwarfed she couldn't talk. And that's and when I was in her belly, releasing adhesions in the vagus, I had a second machine where I ran just 970 and 27. Terror. Not kidney fear, not worry or over concern, but terror. And the belly softened and she just fell asleep.
Right.
And then 23 for the other kind of fear, and then anger. And because, of course, you weren't allowed to be angry about it or tell anybody, which is why you do the throat. And then resentment, and then grief, and then joy. You see how they're layered? Yeah. Especially with that kind of history.
Right.
And so all this time, treating the vagus, quieting the midbrain, I didn't know what I knew. Because she has a central vestibular problem, I knew that the stroke was at least in the lower part of the pons where the eighth nerve comes in. But I didn't know what to do with the pons. So I ran just trauma in the pons. I didn't know whether to quiet it or increase secretions. So I just left it alone. We'll wait and see. And she has magnetic converter. So I wrote a nighttime program that includes concussion and vagus set for the amount of time that she needs it. 81 and 10, disc repair, emotional relax and balance, once again, weighted for how she needs it. And 40 and 89 is in there multiple times for 20 minutes. Because when she got off the table, she said, before I started treating her, she said, I disassociate a lot. I just get out of my body. And it's hard to stay grounded, I thought. So I ran 6.8 and 38 instead of 2 minutes. I ran it for 8 minutes. That tends to ground people. And that's also why I did the energy centers. Does that make sense?
Yeah.
How do you get, so she gets up off the table and she says, I feel normal. I don't have any pain. And because of all the coughing when she had COVID pneumonia, she couldn't expand her chest. So we ran scarring in the vagus and had her breathe, and then scarring in the intercostal nerves. And then someplace in there, yesterday, we ran scarring in the dura. And all of that meant that she could. Sorry. All of that meant that she could breathe and move. And she has a 4, 5, and 5, 6 disc. And she showed me the exercises that the orthopedic PT is having her do. And I went, oh my God, you don't get to do those. She said, yeah, it feels like I'm just shearing and they're having her do this and that. So gave her a little noodle and showed her the little teeny exercises. And so in her body, physical, but the emotional and energetic part and getting the vagus to build a detour around the damaged place in her brain. Both sides of her, that sense of being different on the two sides, that was gone. Her visual distortion was gone. So I had a very good day yesterday.
So did your patient, evidently.
Yeah. What's interesting is at the end, she's been like this for 6 years. She got COVID, and then it's been one medical disaster after another.
Yeah.
And she's got all these diagnoses. She's got a neurologist at the med school that is completely off base. And so as she's getting ready to leave the office, she said, we'll see if it lasts. And I said, whoa, where are you now? What do you mean? Now. if you have your brain expect it to come back, your midbrain will create it. Have me in this little box so you can treat yourself every single night.
Right.
Be here now.
Okay. We got to go back here.
I know.
It gave us a lot. So one of, like I said, the destination on the train, if we're staying true to our form, is you flying the spaceship and me trying to take the spaceship and put it on a train track and take it somewhere. And talk about multiple stops along the way so we understand how we got to the destination.
Yes.
Is one thing we hear a lot of is patients or practitioners want to jump to the emotional frequencies right out of the gate and forget about the physical exam and forget about the physical findings. And I want to stress, in my opinion, and it sounds like in yours as well, is you still have to address the physical exam. You still have to do your range of motion. You still have to eliminate pathology. You still have to do reflexes, sensory exam. You still need to have an objective measure to chart and have that finding that your treatment is a success. It can't just be the patient felt better, felt happier. That is a component of it, but you still need to have that objective marker. And I admit this all the time, when I first started practicing after the first core that I took in person in Austin, I remember listening to the emotional frequencies and just being like, this lady had me, but now I think this is weird. I think this is, give me cytokine, give me scar tissue, don't give me terror. It just didn't compute. However, I proved myself wrong and I talk about that case report with the hockey player who we got 80% of the way there. And it wasn't until either he started talking or I started listening to the component of abandonment, fear, because everything in life was moving on without him. And without telling him that I was running these emotional frequencies, he thought I was still working on his hip because I was testing range of motion in his hip. The range of motion kept getting better and better.
And then you're running the emotional frequencies.
For abandonment, right. For me in my head, I've always been aware of the emotional frequencies that we have to treat, not we don't have to, we get to treat them. But there still is a lot of work that has to be done, either with the muscle, with the tendon, with the fracture, with the disc, with the vagus, with the whatever else is going to be there. And so the question then became, when do you start putting in the emotional frequencies? I guess the answer is it depends. And if you have multiple machines, you also have that option. But I think they're just, you can't start with the emotional frequencies. You have to get the meat and potatoes. You have to get the work done first and then start splicing those in.
Yeah, exactly. And aside from anything else, the emotions, if you think about the fascia as a jump drive, as a storage system, and the hippocampus as the CPU, does that make sense?
Yeah.
The dura is a kind of fascia, and the dura slides has that circle around the midbrain.
Yeah.
Emotions aren't from space. They aren't just feelings. They come from a place, and that place is the amygdala and the hippocampus together, right? So you have the amygdala. Everybody knows that's where the emotions come from. But the hippocampus, if you will, drives a bus. It protects you from emotions that are too strong, emotions that happened in such a way that you couldn't process them at the time.
Right.
So they get stored someplace. That's my idea about the hippocampus. Dr. Wood may correct me over the weekend, but I'll find out. And so it suppresses them. And so the two are just cheek by jowl, they're right next to each other. So you have to work on the physical problem first because that's what the patient came in for.
Right.
They don't know that you get to work on the emotions.
Right.
None of the physical medicine practitioners or psychologists or therapists. It's not your job. It's not why you're there.
Right.
But, and you get to, or you have to treat the whole person to get the physical problem to resolve, because the knee or the hip or the low back didn't walk into the clinic by itself. It came attached to this whole person. And acupuncture meridians, energy centers, nerves, scarring in the vagus, bleeding in the abdomen, scarring in the ureter. And then she mentioned this event that happened when she was 5 and then multiple times after that. But the 5-year-old event is the one that she was in the hospital for 3 months. Yeah. And so she mentioned that in passing on the first day in her initial history, and then went through all the COVID stuff. And then the second day, in part, I think, because I did 40 and 89 for 60 or 90 minutes the first day. Second day, it's like the lid came off, the suppression came off, and she was able to talk about it more and more. And those of you that are listening that have an interest in this, there's a book called Emotions Buried Alive, or Feelings Buried Alive. So they're not dead, they're still there. And so the lid came off. She starts talking about it in detail and more vividly, and what happened, because I'd been working on her belly.
Right.
And it's, when you think about it in terms of sequencing for this particular patient, because not everybody has this kind of crazy history.
Right.
But if you have a patient with mast cell activation or POTS or any sort of vagal dysfunction, you have to ask, what happened to the vagus? Why is it off? Why has it stayed off for 6 years? And that it just flowed naturally.
I think for those of us who are very heavy physical medicine providers, taking these dives into the emotions, into trauma, into all these kind of subcategories can seem intimidating and can seem scary. But if you think of it in the most simplistic terms, that there is something robbing the body of healing because its energy is directed somewhere else. To me, that when it was explained to me like that from a physician, that was my light bulb moment of, yes, I have to at least pay attention to this, because their body's energy is absolutely paying attention to this. And they need their energy for healing. And this is where we come in, I feel like we help disperse the energy in ways where things have not gone before. And that doesn't mean you're like an energy medicine person. That is what holistic healing does, is it enables the body to do its job the most efficiently as possible. Whether that's me being a run coach or me being a therapist, that's your job, is to get people to move and operate as efficiently as possible. So that layering sequence, something else I want to just spotlight for a second, is not every practitioner gets a patient that discloses that amount of history in such a short period of time. I have worked with people for years that have finally disclosed certain parts of their history to me that you think, man, if I would have known this 5 years ago, I perhaps would have treated X, Y, and Z. And it's no fault of anybody's. People disclose things when they feel ready and safe to, and it's our job to just utilize that information as best as possible. So there's absolutely times where you have to go back and layer in certain emotional frequencies, because now you have that information. We don't always get everything treatment one.
Oh, You use that word safety. Sometimes you'll work on a part of the body where the trauma is stored, and then they'll talk about it, but it's the 8th visit, not the first one. So there's that, but I would encourage everybody to, I guess I'll do it in the core and the advanced too. It's if you're going to run the emotional frequencies, you really have to do 40 and 89 first.
Yeah.
94 and 200, 970 and 200, there's that.
Yeah.
But dealing with the intensity of the part of the brain, so quieting the part of the brain that is suppressing the emotion and getting it to stay stuck in the fascia. That's 40 and 89 first, and watch what happens to the body and the patient.
Right.
And then you can run the emotional frequencies. And because you're not a therapist, you don't want them to disclose, they don't need to talk about it. There's nothing you need to say. You're just dealing with the jump drive.
Right.
Just reading with the fascia, the flash drive, where the emotions are stored. And you've got your hand on the patient, so feel it. Feel what happens. If it softens, that's a good thing. 27 ran for 20 minutes. 23 ran for 2 minutes. She wasn't worried or over concerned about this anymore because she's been safe for 50 years, 40. It was the terror of that original event that was stored in the fascia.
Right.
And we just had to take some of the suppression off the midbrain first.
Yeah.
Pretty much so you could access the emotion that's stored in the fascia. That flash drive analogy is pretty good because
beautiful. Yeah, it makes a lot of sense.
You know how you put the flash drive in and there's a little thing that comes up. It says, do you want to allow this? And you have to say yes. That's 40 and 89 is, you have to get the midbrain, the hippocampus to say yes.
Yes.
I like that. That's fun.
You are great at this.
I'm on a roll today. It's like, what can I say?
Almost like you're a master instructor. Just
speaking of which, we have a master class on my calendar.
Yay.
That's pretty fun.
Let's get to some questions before we go.
We have lots of good ones.
We do have some good questions today.
Okay.
Let's go to Lisa's. She has a friend whose 16-year-old daughter has Ehlers-Danlos, occult tethered cord, Atlantic axial instability, and dysautonomia. She turns her head, the bones slip out of place. She has paralyzed her and has paralyzed her 3 times. She's been gaslit by a lot of doctors. Family went to Spain to see some specialists. Could FSM help?
Oh,
she also has instability C1, C2.
Yes. I don't know what the guy in Spain did. I'm hoping he didn't fuse it. Gaslighting, it's just what they do when there's nothing they can do about it. So I'm going to guess it was hysterical paralysis and emotionally based. Duh. But paralysis is what happens when C1 slides into, oh, good. Okay, good.
Guy in Spain did not help and she did not have surgery.
Okay, that simplifies a lot because we have less of a mess to clean up. So you do the Ehlers-Danlos protocol, mention to the family they're going to need a custom care because this will last 1 week. So you do Ehlers-Danlos for the body, and you probably, I see people for Monday, Tuesday, Thursday, Friday. And so you run that 2 days in a row because with that degree of Ehlers-Danlos, she's got at least 4 or 5, probably 4 of the 6 genes. So she's genetically positive to have that kind of instability. 124 and 77 neck to feet, 40 and 10 neck to feet, because with that kind of pain, with that kind of connective tissue, she's going to have leaky discs. She may not even talk about the pain because, at least I have had patients where it's just up here. It's just the back of my skull. It's just C1 and C2. That's what hurts most. Do you have pain in your hands and arms and knees? Yeah, but this hurts more. So go looking for the 40 and 10 and then check the tone in her legs because some of the discs may be crankier than others.
And she's 16, and sometimes their report of symptoms is just not accurate.
Yeah, and being 16 years old, and it does complicate things because the emotional component is way up here. And having the family already, they flew her to Spain, so I must be really sick. So being a sick person in danger is part of her identity. So you have to deal with that, but that comes later.
Yeah.
Fix, measure with a goniometer how far backwards her elbow goes, how far up, do the 9 Baton points and get numbers. Treat her with 124 and 77, 40 and 10, concussion and vagus. With that kind of instability, be sure and do a vestibular exam on her. That makes sense. And so you may have to take 94 and 94 out. I have a version of concussion and vagus that has minus 94 in it. And then, so you got a towel around her neck and one on her abdomen. So you put one on a washcloth on her chest, and you know how we run 124 and 100 to get C1 to stay where it belongs. So you run that for 60 minutes. So this is not somebody for 20 minutes in the middle of a busy day. This is somebody at the end of the day and bring a snack. So you run 124 and 100, and then as that starts to relax the muscles at C1 and C2, have her close her eyes and move her eyeballs and get the suboccipital muscles to contract without grabbing, because ultimately you're going to have to rehabilitate those muscles to take the place of the C1 ligament, alar ligaments, and the ligaments that hold C1 stable. The C1-2 fusion, occiput C1 and C2 fusion, there's so many nerves up there. I've only treated 2 of them, and I was not successful with either one. The nerve pain, it's a mess. It's, if you remember from dissection anatomy, what that area looks like, it's a thing.
Yeah.
124 and 100. So now we're up to 1, 2, 3, 4 machines. And then I'd modify concussion and vagus. So you spend about 20 minutes on 81 increased secretions in the vagus. And the paralysis comes from trauma to the medulla and the upper cord. 40 and 10 will help with that. 40 and 94 in vagal tone will help with that.
Yeah.
This is not a one visit fix. You're talking 6 weeks to at least twice the first week, once or twice the second week, once a week after that, and let the family know the first week that they're going to have a custom care. And if you can go to the advanced compendium, someplace in there is Jody Adams' upper cervical rehabilitation. And I think it was 2017, maybe.
Sounds, I remember the videos with the laser pointer. Yeah.
And I made her do it like this. The third time was finally the best. And then she retired and moved to Iowa. So it's a challenge, but it's doable. Lisa, I don't know what your clinical degree is, but it's doable. Bit of a project.
Yes. Okay. Next question. This person has a friend with a 9 or 10-month-old child. 2 weeks ago, the baby got some sort of virus. It went to her brain. She started having seizures. Doctors didn't know why she was having seizures, but have tentatively now diagnosed her with cerebral palsy. She could no longer sit up and was unable to suck. She's regained the ability to suck, but they've warned the parents she has a long road of PT ahead. Could FSM help? The same thing happened to a 6-year-old cousin to the baby on the father's side.
Interesting.
This is all you.
Okay, concussion. What virus? How high was her fever? 104, 105 fever will cause seizures. If your anatomy is such that you have a seizure focus when you're born, by and large, cerebral palsy doesn't develop from space or from viruses, as far as I know. So I'm not sure which doctors said what or why. So there's that. Okay. So PT is, I'm glad she can nurse now. PT is going to help her have cerebral palsy and function, but you have 81 and 10. You have the frequencies for pretty much every known virus, 38, 41, 44, 56, 160, 189. That's the lot. And run that in the blood vessels, the different brain parts, and treat the vagus. If there's a seizure focus, help the brain develop a pathway around it so that it will work. 81 and 10, increase secrete descending inhibition on the cord will get rid of spasticity. If they diagnosed her with cerebral palsy, my guess is maybe she has symptoms of spasticity. So 81 and 10 will take care of that, but you still have to fix the brain. And by and large, seizures come from hyperactivity. It's this little electrical storm in a part of the brain. So 40 in different brain parts, plus the viruses, plus the vagus, plus 81 and 10. And then by and large, you can't hurt her get any worse. And it sounds like with cousin on the father's side, did it happen when the kid was 6? That's interesting. That suggests some sort of genetic predisposition in the nervous system. One of the things we talked about this week is in anatomy, in medicine, the more you know you don't know.
Yeah.
It's talk about down the rabbit hole. I read Dr. Wood's slides and it's, oh my, wait, we have to, as you would say, unpack this, please. So we'll see. All right.
Okay. So there's that one. A couple more here still. A client reported a series of concussions with something falling onto her head. She's had 2 years of visual therapy and cognitive therapy, but still experiences being lethargic, having brain fog with easy visual fatigue, as well as occipital and neck pain. There's a report of nodules on the adrenal gland that her primary care does not think is related to her being lethargic. Go. Yes.
She needs to see an FCOVD optometrist ASAP.
Right.
Occipital and neck pain.
Yeah.
When you have a vestibular injury, and given that it started with a series of concussions, it can either be peripheral or central, depending on at that age. She's had visual therapy and cognitive therapy, and vision therapy only works if the part of the brain that you're trying to rehabilitate is there. If you've had a concussion that's bad enough that the part of the brain they're trying to retrain isn't there.
Right.
Okay. So I had a SPECT scan of a patient, sent her for prism glasses. They put her in vision therapy, but I had the SPECT scan that showed basically a good portion of her temporal lobe was just not there. And when you looked at the cross sections on the SPECT scan, it was an Amen clinic, there were holes in the places where the eighth nerve goes. So I called Dr. Esky and said, vision therapy is not going to work
Mm.
because the part of the brain that you're trying to rehabilitate just isn't there. So if she's had 2 years of vision therapy, she's ended up with an FCOVD or a physical therapist who does vision therapy. So I had an FCOVD in one of my classes that I don't do prism glasses, I do vision therapy. They make more money that way, but it's sometimes what you need is prism glasses. And the reason she has suboccipital and neck pain is that when your brain doesn't know where it is in space, it has to increase proprioception. And it does that by tightening up the neck muscles.
Right.
So the other thing I had on this stroke patient that I was talking about first was 40 and 44. Quiet the inner ear. I didn't want to mess with the pons, but quieting the inner ear relaxed her neck muscles.
Right.
Oops.
Yeah.
So
the last thing is, will things reset with concussion in Vegas? No, you could run concussion in Vegas every day, and I don't think that would help.
And the fatigue is really simply from exhaustion.
Right. Trying to focus, trying to concentrate, trying to take the information through the eye into the brain is exhausting when that doesn't happen.
Yeah, so don't let them do anything to the adrenals. I don't know if you're a naturopath and are tempted to treat the adrenals, but it has nothing to do with her fatigue. The fatigue it's exhausting.
Sure.
Vestibular patients are tired a lot.
Yeah. And then the last question, I think this was on the other chat. So Jenna is asking about a substitute for using scarring with hypermobile community.
No, you still have to treat scarring in the vagus, scarring in the nerve, scarring in the artery, but you can do that with a second machine that's just running 124 and 77. You're not trying to release scarring in the connective tissue. Usually you're trying to release scarring in a nerve, scarring in the vagus, scarring in the small bowel, scarring in the dura.
Yeah.
You can do that and run 124 and 77 at the same time. Oh, the patient from Monday and Tuesday that had all the trauma and all that stuff?
Yes.
Okay. She said, oh, now after I got her ribs moving, she said, maybe my mammogram won't hurt so much tomorrow. And I went, why does your mammogram hurt? And she said, oh, I've got this calcium nodule on my left breast. It's about, I don't know, she made a circle that was about 1 centimeter across. And they've been following it for years. And Karen Perry published a paper, 217, in the breast that had really dense breasts. So I had the patient show me where the marble was. I put a washcloth over the breast and ran 217 calcium oxalate and with the mammary gland and had my finger on it, and it started to get smaller and smaller. And then I ran 217 and the ducts and 217 and the fascia, and then scarring in the sclerosis in the adipose.
I was waiting for that one. I'm like, that one's got to be in there somewhere, I'm hoping.
Yeah. But then, thank you, Karen Perry, back to 217 and the mammary gland.
Yeah.
And she's feeling it and said, I can't find it. It's gone. Yeah, gone. Like it went from 1.5 centimeters to gone in 20 minutes. And it's okay, you're getting a mammogram tomorrow.
Let's see this. Yeah.
Yeah. And then we'll have another paper published on reducing calcium nodules in the breast. Isn't that cool?
It is so cool.
I love being us.
Wow, amazing. And even if the mammogram still sees it, the fact that she didn't feel it and it wasn't symptomatic or something that was going to hurt her is still a success right there.
But it was not palpable before.
Wow.
Oh, and Sylvie wants to come be an instructor in Phoenix, and I got to see where we are with that class and instructors. Oh, way over. Way over. We have lots more instructors. Sorry, Sylvie.
I'm good too right now. Thank you, though.
Yeah.
Another question, how to treat dry macular degeneration at early stage?
Unless you're an optometrist or an ophthalmologist, you don't.
Yeah.
Period. End of discussion.
Yeah.
No exceptions to the rule, not even for me.
Yeah.
Nope. And
Yeah.
that is because the reason is that you have to be able to examine the eye before treatment or after, well, and after, to make sure it's still dry macular degeneration. The thing that freaked me out was the optometrist that said dry macular degeneration can go from dry to wet literally overnight. No way to predict it. I couldn't tell you what macular degeneration looks like
Right.
if you paid me or
Yep.
right, threatened me. Unless you can examine the eye, I would say treat the blood vessels, treat insulin resistance, get them to get their A1C down to 5.7. If that involves insulin resistance and leptin resistance and a continuous glucose monitor and Manjaro, I don't care. It's macular degeneration is about the blood supply to the retina. And so you can treat the capillaries for inflammation and increased secretions and vitality in the capillaries. Maybe that you can't hurt that. You're not treating the retina, and you're inside your scope. That's the trick.
Yep.
And then the 6 virus frequencies go to the flu respiratory webinar. We can now call it COVID because they don't care. Back in 20, when I did that webinar, you couldn't call anything COVID if you weren't an ER doc.
Yeah.
So it's 38, 41, 44, 56, 160, and 189. So there's influenza, there's London flu, Spanish flu, malignant flu, those
flu guys.
Those guys. And wow,
and it's 4 o'clock.
It's 4 o'clock.
Oh,
how you doing? Are you doing okay?
I'm leaving this with a lot of ideas and a lot of things I want to look up.
And thinking about layering, right?
Yeah.
So yes, it's like the knee,
Yeah.
your topic. You got to treat the knee, but you also, there's no point unless you look at the foot,
And
the
the hip.
tarsals, the talus, the arch, and the hip.
Yep.
And the emotions are the same way.
Yeah.
It's
a beautiful layered lasagna. I have that slide in there too.
Oh, of course you do.
And it's 4 o'clock and that's it. And this was great. So thanks everybody. Those were really good questions too. Wow.
Yeah, it was a great day.
We'll see everybody. Will you be here next week? Or are you already in?
Oh, we'll be doing the core next week. We're going to be in Phoenix. Kevin shipped today a pallet, 2 pallets. Yes, 3 pallets yesterday because we're shipping both the core and the advanced. Yeah. And then apparently I have to bring all 6 or 8 of my precision cares from the clinic for the core. The core is huge. I think we ended up closing at 42.
That's and then sports course right now too.
Yeah.
They're a hungry bunch this year.
We're there. There's this tipping point thing happening. I'm so excited.
Me too.
Yay.
We will do the following week a little bit later than scheduled, but you and I will be live in Phoenix.
That's always so much fun.
I know. It's my favorite episode of the whole year.
Yeah. And David Eakes is it's his favorite.
Oh, I love it. Yes.
Everybody does. And we have a live audience.
Yes.
Yay.
Okay.
Hey.
We'll let everybody go and keep registering for the advanced because we're going to be there and it's going to be fun and you can do it live stream and all that stuff.
Ooh, I got Dave Burke's slides this morning. Oh my God. You just
Brain
like,
candy, I'm sure.
so this is like I think from now on we'll do a 4-day advanced and just more case reports to make it into a symposium year.
Do it.
And the ARM, American Academy of Resonance Medicine, is up and running. And we have a donor plaque and we have 501c3 thank you for your donation notes and credit card swiper. And it's like a real thing. And
yeah,
I'm so excited.
As it should be. Yay.
Yay.
Let's go.
Okay.
Okay, everybody.
See you in 2 weeks.
All right. See you then.
Bye.
Bye, everybody.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts, or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.